Hello, my name is Dormico Walker, and I'm a psychiatric mental health nurse practitioner, doctoral candidate for the Maryville University of Catherine McAuley School of Nursing doctoral degree. I'd like to share with you today a PowerPoint highlighting my quality improvement project entitled Non-Suicidal Self-Harm Screening in the Adolescent Patient. So this is a slide of my chair, Dr. Boniface Stegman, who was a key point in helping narrow down the criteria's ideas needed for this presentation. These are a host of my professors, and lastly, my psychiatric clinic supervisor within the clinic that I did the actual quality improvement project in. So adolescents today are faced with significant problems, obviously from gender dysphoria to mental health illnesses, right? The number one thing that they're dealing with in addition to mental health illnesses is non-suicidal self-harm injury. This is problematic because when healthcare providers don't identify this, um, they're not able to treat or they're not able to address the maladaptive behavior. Self-harming behavior is defined by different ways. One can self-inflict injury and or intentional damage to the body despite suicidal, non-suicidal intent. That means it doesn't matter if they mean to or if they don't mean to. Intentional or non-intentional self-harm is still a way that you can cause harm to the body. Self-injurious behavior is of utmost importance because it can often transition into suicidal ideation and suicidal attempts. There is a poll taken from a report from Holden et al. That suggested that 41% when asked of self-harming patients, they endorse suicidal ideations, and 70% endorse having actually attempted a history of suicide. So the aim for this quality improvement project is to relate that by using the Z-test to show the difference between two proportions. When very similar questions are asked differently, different results are given. In this example, for this test, or for this quality improvement project, the Z-test proved that the self-harm inventory screening tool produces more information pertaining to self-harm or self-injurious behavior than that of its counterpart, the PHQ-9 or the GAD-7. And I clumped those two together because the patient used either the PHQ-9 or the GAD-7 against the self-harm inventory screener. The additional aim would be to show the need for detailed screening within this adolescent population, identify methods used to report the increase in reported self-harm behaviors using the self-harm inventory screen versus that of the PHQ-9 and the GAD-7 screeners. And lastly, identify the implications that using the self-harm inventory screener would have in practice. So we did a review of literature before we got started, and I used keywords like non-suicide, self-injury, adolescence, depression, anxiety, abuse, cutting, screening, non-suicidal self-injury, self-injurious behavior, etc. I was careful not to use articles that involved neurodegenerative disorders, autism spectrum disorders, or any other diagnoses that I excluded from the inclusionary guidelines list for my participants. Literature search was used from the Maryville University online library system. I went into Medline Complete and EBSCOhost, and of that search, found 737,551 academic journals, 1,677 magazines, and 895 articles. Yes. by the time I filtered it down using most of the keywords in the balloon, um, I came close to 109 articles that was relevant to what I needed to use it for this project. So the theoretical framework that I looked at when I had this question was I looked at the impact that the Havelock theory framework had. I was interested in it, and I thought that it resembled a lot of my thoughts, so it felt like I wasn't recreating their will here. The Havelock theory represents the necessary steps toward creating an environment of change, and that is what I was trying to do. Trying to implement with this self-harm inventory. It's labeled from 0 to 6, the Havelock's theory of plan change. And it starts off with 0 being that of identifying what needs to be changed. So the second thing, or the number one thing, would be building a relationship with those that may be able to influence change. Diagnosing the problem or the breakdown in communication, finding out where the problem is and what needs to be changed. Acquiring a relatable, relevant source to support one's ideas. Choose the solution that best meets the needs of the problem that you're attempting to solve. Share the information studied and apply the new approach to create a stable change that has the ability to sustain over time. These are all things that I've done in my quality improvement project. Do you see how closely they relate to Havelock's theory of plan change? The method used was the chi-squared upper tail z test. This test tests the difference between two proportions, and this was significant because it grasped the concept of taking two independent proportions and comparing them for likes and differences. We needed to identify the null hypothesis, and in this particular case, the null hypothesis stated that the two proportions, one being the PHQ-9 and the GAD-7, and the second proportion being the self-harm inventory, would produce the same results. Because there was a noticeable difference between the two, the inferences was that the null hypothesis had to be rejected. The recorded difference between the two was 0.313432836. The z-test statistic was 3.6693. There is a difference in reported self-harm with the use of the self-harm inventory versus that of the PHQ-9 screener, and that is what was shown. And in addition to there being a difference in results, it also predicted that there will be an upward trend using the self-harm inventory screener if it continued to be used. So if we continue to use the self-harm screener, it predicted that we would have more patients reporting yes to that screener than that of the PHQ-9 or the GAD-7. So who is my sample audience? Well, firstly, I have two groups. And the first group was a live group in person, so either live in person or over the Zoom, male, female, or if they did not identify as either one, we call it the unisex. And that sample of group, they were doing the self-harm inventory screener. The second group was the retro chart group. So I had a sample of patients that met the criteria, equal female, male, or unisex. And I took the old PHQ-9s and GAD-7s that had been administered before. There was a total of 134 participants, 67 for group 1 and 67 for group 2. The overall study had to include that all of the participants met their requirements. The requirements were that they needed to be between the ages of 13 and 17 during the time the data was collected, and have a psychiatric mental health disorder documented in their charts. The only exclusion in this case here was that they could not be over 17 years of age and that they could not have a neurodegenerative disorder such as autism or something of that spectrum on that spectrum. When applying results to the graded scale, the PHQ-9 and the GAD-7 screeners, they were reported as having a 9 or greater positive for self-harm. They were given a 2. If they were reported as having a less than a 9, then they were given a 1 for no self-harm. As far as self-inventory goes, on the graded scale, if they had a score that was greater than 5, it was a yes for self-harm, and if it were less than a 5, it was a no or a 1. And so here's the chart that I used. And like I mentioned there on the legend, there are 2 on that y-axis there goes up to 0 to 2. 2's for yes, reported positive harm, and 1 is for no, no self-harm. And then I went on to explain again how I got the positive if the PHQ 9 or GAD-7 scored higher than a 9, they were positive for self-harm, and if they reported self-harm as well. And self-harm inventory scored higher than a 5, they were absolutely positive for self-harm. Of the 67 retrospective charts reviewed, there were 28 males, 69% females, and I believe there were 2% unspecified sex. Of the self-harm inventory screeners, there were 25% male, there were 67% female, and 8% unisex. So after the description of the patients given and the breakdown of the groups, I was able to show that the gender and age group recorded identified more so with the self-harming behaviors screener by way of reporting self-harm more so with that screener than the PHQ-9 or GAD-7. And again, you can look at the screen and tell that they're kind of neck and neck a little bit, but for the most part, according to the numbers, the self-harm inventory screener did receive more results of yes. This is a plotted graph that denotes the standard deviation of the 2 screeners. The lower limit is 0.1546 and the interval upper limit is 0.4722. This is a reflection of a true change in ratio between the PHQ-9 and GAD-7 and the self-harm inventory screener. The calculated Z-score was 3.6693, and that number is more extreme than the cutoff Z-score. So the achieved power of this study was 0.9836, which indicates a high level of strength, or that it is highly unlikely that the 2 proportions would generate the same result. So the area that produced the most limitation for this author was the inclusionary-exclusionary criteria area. Most of my patients are undiagnosed autistic patients with self-harming behaviors, so it was very difficult to identify who was actually self-harming as a result of generalized mental illness from such illnesses such as bipolar, borderline personality, anxiety, depression, or who is actually self-harming because of a neurodegenerative disorder. The additional piece to the limitation included aging out of some of my inclusionary aged patients. Some of my patients were 17 and soon to be 18 within that following 6-month window of time uh, between collecting information, collecting data, and analyzing it. The patient was turning 18 6 months later down the line. I would discard that participant's information because by the time I could use it, it would be too late. They would be 18. This called for a longer period of time needed for me to be able to screen more patients. So I was still unable to um, control my patient population. It's very difficult when they come in to know exactly what you're going to get. But even so, I still made sure that we met the requirements by extending the time frame for assessing more patients. So why am I doing this? What is the significance? Early detection, early identification, accurate identification may help to save a life. According to the Center for Disease Control and Prevention 2002, youth that engage in intentional self-harming behaviors are at risk for suicide. That's the bottom line. I'm interested in secondary intervention, uh, screening the patient to offer early detection and diagnoses. Apart from worst case scenarios, identifying non-suicidal self-harm can also prevent the risk of wound infections from self-inflicted cuts, as well as prevent self-mutilation. The evidence obtained from this DNP quality improvement project is congruent with the reported high correlation between self-harming injury screeners and self-harming behaviors. The takeaway here is continuance of non-suicidal self-injury can lead to unintentional death. So early detection of maladaptive behavior and prompt treatment can promote the discontinuation of these harmful behaviors. Gaining clinical communicative skills through the act of direct questioning will help prevent future self-harming behaviors and promote a safe and positive environment that will lead to a positive outcome throughout the patient's life. It is important to use the appropriate form of questioning with a vulnerable population such as the adolescents who might not otherwise openly give specific information at first. Identifying self-harming behaviors in a sensitive manner is conducive towards establishing both a relationship of trust and preservation of dignity for the patient. So what is the conclusion? This project supports the beneficial use of direct questioning and screening techniques used to identify self-harming behaviors in the adolescent patients. It provides evidence towards the distinctively different outcome that using the self-harm inventory screening tool can have on an individual versus generalized questioning in the use of, well, with the use of, such as with the use of the PHQ-9s or the CAD-7 screeners. Adolescents managing mental illnesses are largely difficult to extract information from. Talking with the patient, asking specific questions in a timely manner, and receiving answers that support a specific area of concern allows the provider more time to gather resources, put together an effective treatment plan. So the bottom line here is there are no simple remedies to lead to the end of self-harming behaviors. The idea here is to identify behaviors quickly, efficiently, so to prevent the adolescent from continued and or worsening behaviors now and later on in their lives. Any final questions? Let's have a discussion. And that concludes the end of my presentation. Thank you.